I think the main benefit for TEE and really POCUS in general is about phenotyping shock. Is this RV failure, LV failure? Once you have that done, the serial and iterative refinement of patients over the span of days can be done by other tools. Looking at end organ perfusion, be that cap refill, modeling, lactate, urine output. There's other markers we can use to titrate our therapy.
Welcome to Critical Care Time, the podcast for everyone who cares for people with critical illness. I'm your host, Dr. Nick Mark.
And I'm your other host, Dr. Cyrus Askin. On this week's episode, we're going to talk about a very useful tool to add to your ICU toolbox, Resuscitative Transesophageal Echocardiography, also known as TEE.
Anyone who listens to the show knows that we are big fans of point-of-care ultrasound, and TEE is a really good ad because it solves some of the big frustrations, namely that you can't always get the views you need, you can't always get the measurements you need. Sometimes you're doing other stuff like CPR or other procedures, and TEE goes a long way towards solving the limitations of point-of-care ultrasound. We're very fortunate today that we have a guest with us to share some wisdom. This is Dr. Ross Prager.
Dr. Ross Prager is an intensivist and researcher from London, Ontario, Canada. He is interested in critical care ultrasound, as you may have guessed, especially TEE, and knowledge translation. He is particularly interested in research efficiency and impact. We're super excited to have you on the show, Ross.
Hey, thanks for having me, guys. Huge fan of the podcast and just excited to be here and talking about TEE.
I mean, I think I am ready to learn a lot, so let's just get started.
Let's do it.
So I think probably the first thing we should do is we should define resuscitative TEE, which is really two questions. What's TEE and what's resuscitative TEE? How is that different?
I think I can answer. You just take the phased array and you shove it down the esophagus, right?
That's right. Yeah, just
and then you're done.
Swallow this.
Yeah, there's sometimes a little bit of resistance, but once you overcome that, it's pretty easy.
Okay, no, in all seriousness,
when we talk about medico-legal implications, we're gonna loop back to this part.
Yeah. No, okay, Ross, let's set me straight here. What is TEE? What is resuscitative TEE, and why should I care?
So as most of your listeners probably know, transesophageal echo is a modality where the ultrasound probe is inserted into the mouth and then down into the esophagus to image the heart from behind. This means when you're looking at the images, it's actually flipped from the classic transthoracic views. You have the atria at the top of the screen when you're in the esophagus, and the ventricles kind of in the far field on the ultrasound. And more specifically, the probe actually sits right behind the left atrium in the esophageal views. And this makes it perfect for assessing for things like left atrial clots, valvular pathology, assessing the aortic arch, which previously is pretty inaccessible by classic transthoracic. And really, traditionally, TEE has been in the domain of cardiology or cardiac anesthesia, particularly in the pre- or perioperative period. But for the past few decades, certain pioneers and clinicians have been using TEE outside of these traditional domains. And I should shout out some of the kind of leaders of resuscitative TEE, Dr. Paul Mayo, Rob Arnfield, Antoine Villabaron, and others that have really helped spread this modality to diverse providers, not just the traditional cardiology and cardiac anesthesia. And really, resuscitative TEE is sometimes referred to as goal-directed TEE. We're not trying to systematically quantify the filling and function of the heart. Instead, we're really focused on answering these questions for really, really critically ill patients. And in some ways, it's analogous to point-of-care ultrasound and the comparison between point-of-care ultrasound and transthoracic echo. It's not designed to replace echo, but instead allows diverse and kind of more providers to answer focused questions that can really vary with the level of training. For the novice, it might be, is there a big pericardial effusion and tamponade? And for an expert, there can be complex hemodynamics. So Resus-TEE is really a tool that's now being used by emergency physicians, intensivists, anesthesiologists, and really anyone who's managing critically ill people. And it's actually not that hard once you get a bit of practice as well.
That's a great overview, Ross, and super excited to be talking about this. I know when I was in fellowship, it was sort of just somewhat emerging within our program as a modality we were starting to pick up, and now I think they've really taken it and run with it. And that's sort of in keeping with the trends I've seen, at least across the United States, as TEE has become more commonplace in ICUs, emergency departments, and places like that. But, you know, as intensivists, we all love our toys, and is this really just kind of another toy to do the same job we've already been able to do with surface echo, or you know, what's the added benefit here to TEE?
Yeah. There's really two parts to any ultrasound or POCUS exam. There's the acquisition, but then also the interpretation. And when we're dealing with resuscitation in critically ill people, acquisition is really, really hard, as we all know. Body habitus, maybe technical skills and experience of providers, other pathology that might be competing, for example, subcutaneous air, or just other competing clinical priorities. And TEE really overcomes these barriers. You just put the probe down and you have a near perfect view within seconds. You also don't have the same kind of physical real estate. We've all had situations where you're trying to get that POCUS, the subxiphoid view during the cardiac arrest, and somebody's elbowing you out of the way to do CPR. Once the probe is actually inserted, you can actually image from kind of a little bit further away at the head of the bed or on the side of the bed, allowing for more physical real estate around the patient. And then it's also repeatable. Instead of having to struggle to reacquire that apical view to get a repeat measurement, once the probe is in situ, you can hang it up on the bed rail or on a stand at the head of the bed, and it just stays there. And you freeze it, and you unfreeze it. And for the duration of the resuscitation, be that minutes or even hours, you can actually serially image the heart and reassess in real time what's going on from a physiologic and anatomic perspective. And so certainly that's a huge value add to POCUS, and it really saves a lot of time once the probe is actually inserted.
Excellent. Yeah, that's a great overview of its unique advantages. Let's talk about, like, when do you go for it? What are some clinical situations where Resus-TEE really adds value in your ICU?
There's a few domains in particular I think about. Undifferentiated shock, respiratory failure, cardiac arrest, trauma, and also procedural guidance for things like ECMO cannulation or some other procedures that we can talk about. But if I had to choose two really, really great indications for resuscitative TEE, it would be cardiac arrest and undifferentiated shock. I find that when I have these patients rolling into the unit, it's one of the first tools I reach for because, again, you can put it in, and once it's inserted, you can leave it in for hours while the patient's really unstable and you're trying to figure out their trajectory. When they arrest or re-arrest, you have it there as just another monitor that's giving you such valuable physiologic and anatomic information, really in real time for the duration of the arrest and beyond potentially.
I guess one quick point that I realized we didn't say up until this point is this is in intubated patients, right? That this is not something that we're using in people who are, walkie-talkie awake.
Yeah.
Just to emphasize that minor detail.
Yeah, and I think that's really for two reasons, and we'll touch on that more when we talk about some of the complications of TEE, but really it's from having a protected airway mitigates a lot of the risks of TEE, sedation and aspiration. And also the patients that are sick enough that this provides so much benefit are going to be intubated for other reasons. This isn't the person on the ward that you're struggling to get your subxiphoid view on, but they're on 2 liters of oxygen.
Does this person really need to come to the ICU? Right.
Exactly. This is for people who are dying or are dead, and you want to have the best tool possible to image them at the bedside.
So I love that. I love all those indications that you've sort of walked us through, Ross. The particular ones, cardiac arrest and kind of like undifferentiated shock, are, I think, near and dear to our hearts here on Critical Care Time. Maybe we could start by double-clicking on some of the specific uses of resuscitative TEE in CPR.
I think cardiac arrest is one of the best uses of resuscitative TEE, and there's sort of 4 things that it helps with. First, identifying the etiology of the arrest. Next is actually positioning chest compressions to improve CPR quality, which is a really exciting advantage to TEE. You can identify cardiac arrhythmia, like fine ventricular fibrillation that's not seen on surface electrodes. And then again, that ECMO and that procedural guidance, which can be very useful intra-arrest. From an etiology of arrest perspective, this can be challenging on surface POCUS. Part of it is that you have somebody doing compressions, so you can't spend 20, 30, 40 seconds looking at the heart, and you may not have the views that you would normally want to really explore the etiology of arrest. TEE overcomes this, and in one of our scoping reviews that we did, in 25 to 35% of patients actually identified the etiology of arrest. A huge value add as well is with CPR placement. Currently, we use a one-size-fits-all approach to CPR. We do compressions on the lower part of the sternum, 5 or 6 centimeters of depth. I'm not sure how many inches that is. As Canadians, we go in centimeters here. But we all know from people who've done point-of-care ultrasound of the heart can be wherever you want in the chest. For some patients, it's the parasternal views in the 3rd or 4th intercostal space, and other people, it's in their armpit with cardiomegaly. Maybe they have COPD and hyperinflated lungs, and the heart's pushed all the way down. So one of the really interesting things that's come out of the TEE literature is that when you look at where CPR is being done, if you just do it blind, about 50% of the time, that's half the time, CPR is not done over the left ventricle. It's done over the left ventricular outflow tract or aortic root. And that's really bad. So to have CPR be effective, you need to push on the LV and blood has to come out of the LV, out the LVOT, into the aorta, and the aortic valve has to open. If the aortic valve isn't opening, we actually don't have forward flow. And what's been shown in the literature is that the rates of ROSC and the rates of survival are much lower when CPR is not done over the LV and it's done over the LVOT. And with TEE, we can actually visualize this and we can correct and move CPR placement in real time. And this has been a huge part of the Resuscitative TEE registry, which is looking at this and how we can use TEE to improve CPR quality. And it's not rare, it's 50% of patients. And it's been something that's really changed practice and does change practice in almost every code that I run where TEE is in there. We're positioning CPR to improve CPR quality to give our patients the best chance of survival.
Ross, I have to chime in real quick and just, we just had a code that I was helping out with in our emergency department the other day, and just kind of thinking about, we didn't have TEE available, and I don't personally think that would have necessarily changed the outcome here. Of course, I can't say for certain, but we definitely encountered some of those issues, particularly with the logistics of, you're trying to do CPR, even if you have a Lucas device or something else that's taking up less of a footprint, you're still trying to navigate around that to get good views of the heart. And then, the fact that you really cannot image the heart effectively with surface echo while doing CPR is something that, frankly, I never really thought about as a means to provide some quality assurance. So that's super exciting, Ross. Thanks for sharing that.
I think one thing to add too is just, anecdotally, right? I mean, how often have you seen the situation where somebody is receiving CPR and the end tidal is low, and then you change compressors and now it's high?
Oh, yeah.
And it's like, oh, what happened? Was that last person not pushing very hard? No, in many cases, what you're seeing is this. You're seeing that the placement is subtly different and it's delivering effective blood flow, whereas previously it was ineffective. And it's a really humbling thing, like to your point, Ross, that 50% of the time are using external landmarks for CPR doesn't put our hand in the right place. So huge value add here.
Yeah, I think back to a cardiac arrest I managed some time ago, and it was a witnessed VF arrest, and we were right there, and the end tidal when we got the patient intubated minutes later was like 8, and it looked like it was really good compressions, and we were just kind of thinking that's weird. And so the TE probe came really quickly, we put it down, and there was absolutely no aortic valve opening. And as soon as we moved the CPR down, and we actually had to move it down to below the sternum, almost like mid left chest. And I'm not advocating this as a CPR position. Please don't hold me to this. But in this situation, that's where compressions needed to happen. And the end tidal
is listening, and they're very upset.
Yeah, I know. The big brother is listening. But the end tidal CO2 went up to 45, and there was ROSC shortly after. Wow. And and you could see the aortic valve that wasn't opening start opening, and you could see the cardiac output happening in real time. And as soon as you see a case like that, the idea that a one-size-fits-all to CPR seems kind of silly in retrospect.
Yeah, Ross, I think that's really an interesting story, and it in my mind, it foot stomps the ability to use TEE to sort of view the resuscitation in parallel as opposed to in series. In other words, you're sort of like making those adjustments in real time. You're watching the benefits of those adjustments under direct visualization rather than having to guesstimate with your pulse checks and whatever. And let me take a quick look, and okay, maybe you can move up a little bit or down a little bit, or and then invariably you're taking more time to do more pulse checks, which is less time on the chest. And so that's a problem in and of itself. So yeah, super, super interesting. I know we've got a lot of other points, but that in and of itself has me very excited.
Yeah, and that's beautifully put, the parallel versus series. I love that analogy. Yeah, a couple other considerations is that in the literature, and certainly I've seen this a couple times, that when you put the probe down, a patient who is asystolic on their ECG or on the monitor, actually is in fine ventricular fibrillation. And this was reported in up to 12% of cases in the literature, where you can actually identify fine VF that may respond to electricity as opposed to it being asystole, which is interesting. And then the last thing is that during ECMO cannulation, the ability to confirm that there's not two guide wires in your venous side if you're doing veno-arterial ECMO cannulation intra-arrest is super important, because inadvertent veno-venous cannulation for eCPR is something that's talked about a lot in the literature, and it's very, very easily ruled out via TEE.
I think it's an incredibly useful tool for ECMO cannulation. We do a lot of VV cannulation, and there getting your cannula positioned just right. It's also super useful if somebody has a device in, like an Impella, and you want to make sure that the device is properly positioned. I mean, it's just like there's a lot of things when you get into the device world where getting good cardiac views in real time, it can be a game changer. All right, so we talked about cardiac arrest, some real value adds there, better CPR, identifying root cause, continuous feedback on CPR, just like we would do with rate and depth. Now we can also do rate, depth, and placement. Let's move on to undifferentiated shock, which, by the way, great throwback to our first episode of Critical Care Time about undifferentiated shock. So if you haven't listened to that, go back and listen. This will tie in beautifully. In that episode, we talked about how point-of-care ultrasound was an incredibly useful tool to identify the category, one of 4 categories, and the specific etiology. So, Ross, how does TEE add more nuance, more data to that assessment?
Yeah, I think if you have perfect transthoracic views, I'm not sure TEE adds a ton. Like, if you have perfect echo views, you have perfect echo views. You can answer a lot of those questions. What I think the big advantage is in our sickest patients, it gives you those views within seconds. Once the probe's inserted, you have great images of the heart. You can do serial reassessments. You can reassess them every 5 minutes without having to struggle to do that. And to quote Rob Arnfield on this, bring a gun to a gunfight here. You have your sickest patient in the hospital. You want the best data you have from the get-go. Struggling around trying to get suboptimal views just doesn't make sense when you have a patient that's dying or could die in front of you. There are a few specific cases that we see with TEE more than transthoracic echo, perhaps, just because we're doing it on sicker patients in the midst of either intra-arrest or peri-arrest patients. That's things like dynamic LVOT obstructions with intracavitary gradients that you can see in these moribund patients when the probe's in there, and you can really kind of see the response to therapy over minutes to hours. You can calculate cardiac output using left ventricular outflow tract VTI, and it's pretty easy to get kind of repeat assessments over time that have similar angles, so you can really compare pre and post intervention, be that fluid bolus or perhaps even like an inotrope challenge. And then you also get a unique assessment of the aortic arch. So in certain settings where you want to rule out an aortic dissection in the intra-arrest or peri-arrest patient, and also of the pulmonary artery. And so you can actually visualize clot in transit. You can sometimes see like saddle PEs sitting on the main PA. And then you can actually pulse wave the PA and look for patient-ventilator interactions to really understand things like optimal PEEP studies. Those are certainly more kind of advanced applications for TEE, but all uniquely offered by just kind of the anatomy of it and the fact that you're imaging from behind the heart, which are adjacent to these structures that we have a lot of trouble imaging with transthoracic views.
Yeah, I think that's a great list of situations where it can be helpful. I think in particular, I really like the ability to do repeated VTI measurements, because VTI is like a great measurement, but often it's very sensitive to positioning. And so even the same operator doing it an hour apart, the patient's been shifted around in bed, and like, it's just really hard to get numbers where you're confident it's an apples to apples comparison. So having a probe that you can leave in where you can do that is a big value add, in my opinion.
Yeah, similarly, Nick, I think that the cool thing that I'm visualizing about resuscitative TEE is it's kind of the best of both worlds of surface echo and a Swan-Ganz catheter in a lot of ways. Because the nice thing about a Swan is once it's in, assuming you can get it in, you're able to get data, longitudinally. But oftentimes what I've found is the Swan data, or oftentimes in our ICU, it's like a hemisphere or something like that, because, we don't take the time to float the Swan or whatever, the cardiac output data and other data that's being placed on the monitor, doesn't necessarily correlate with what I'm seeing on my surface echo. And then I'm kind of like, well, what do I trust? Well, I tend to trust what I'm seeing with my own eyes as I'm watching the heart contract and I'm taking these measurements, etc. A lot of those issues seemingly could be mitigated by using a TEE probe in this way, placing it, keeping it in the patient as you're making your interventions, and then watching in real time the changes to contractility, the changes in cardiac output as measured by these very useful hemodynamic parameters. So super exciting, I think.
Yeah, and maybe I'll just add one thing. There's been some literature on VTI variability from transthoracic echo, which can be 10 to 15% from the same provider on repeat assessments. And I actually don't know what it is for transesophageal echo, and there is some variability there as well. But I totally echo what you're saying. There's less kind of anatomic variability because you're confined to the esophagus and the stomach when you're imaging. So you can't go too rogue. You can't wander off into anywhere that's going to cause too much measurement error there.
And that, by the way, is a pretty scary number, right? I mean, a 15% measurement error, because usually like 10 or 15% you would consider the threshold for like volume responsive, right? So the fact that you can get those kind of error bars just on repeat measurements, is scary because it can confound your assessment.
So, Ross, let me ask a question. Moving to a slightly different population, trauma patients, burn patients, those sorts of folks. Is there a place for transesophageal echo in those individuals? And if so, how would you view its utility?
We actually looked at this in a retrospective study looking at 54 acute trauma resuscitations where we used TEE at our institution over a number of years. And this was actually in the trauma bay or in the ICU immediately after kind of their post-trauma bay or post-operative stay. And what we actually found was that a new diagnosis was made in about 57% of cases, most commonly actually RV dysfunction that wasn't seen in 19% of cases, or some sort of pericardial effusion, or occult hypovolemia. And what this kind of really challenged for me is the idea that all traumatic shock is either obstructive or hemorrhagic. We're actually seeing other phenotypes of shock as well, be that acute RV failure, dynamic LVOT obstruction, which we can chat about a little bit. But it was certainly challenged some of the traditional thinking that I had about trauma, and it provided a fair bit of utility as well. It actually changed management in a reasonable percentage of patients. In 32% of patients, it changed the resuscitative strategy, so perhaps inotropes, vasopressors, fluid, bloods. Diagnostic imaging approach was changed in 11% of patients. The procedural or operative approach was changed in 9% of patients, and in 7% of patients, it actually changed the disposition from the trauma bay. And for example, one of the cases was a patient that had a aortic disruption that was seen on TEE, and the patient was actually brought immediately to the OR for intervention instead of undergoing kind of traditional imaging because they weren't particularly stable. And that patient may have deteriorated by the time they went through the CT scanner and then up to the operating room. And I'm certainly not advocating that this is standard of care. This is certainly something that needs more research and needs prospective research to really understand, but is an interesting potential value add because the same principles apply to trauma patients. You have limited access to their trunk. There's other competing priorities. They have subcutaneous air. All the things that make surface echo challenging in this patient are reasons why we could use transesophageal echo potentially.
Ross, I'm really glad that you mentioned that one kind of caveat of this isn't really the standard of care, because I know a lot of our listeners are going to say, okay, cool. This sounds really fun. This sounds neat. I see the value in it, but in a tool in the hands of an untrained operator quickly becomes a weapon. And in this case, my concern would be time. You're in there, you're kind of putzing around, maybe you're having some issues, you're not as familiar with it, and that time could result in delays to care. And so it sounds to me like while this has tremendous potential, it really does need to be implemented in a mindful way at the institutional level, and that probe needs to be placed in the hands of folks who know what to do with it.
Couldn't agree more. Yeah. I think with POCUS in general, there can be a problem when too much weight is placed on the POCUS findings, and that can actually result in delays. In the CPR literature, surface POCUS, for example, has been associated potentially with increased duration of pulse checks, which is obviously very bad because that limits CPR quality, versus transesophageal echo has been associated with shorter pulse checks in the literature. So similar things in trauma or really any patient. You don't want to get fixated on it, but I think in some cases it certainly can expedite care.
Ross, I think that's a great point. So obviously we want to make sure that the probe is in the hands of a skilled operator. And if that is the case, then as you kind of mentioned before and then foot stomped again, you really can provide better, more efficient care in theory by reducing time off the chest, reducing pulse checks, maybe getting to the root of the problem faster than you otherwise would. And so I think that's a really important way to look at it. It does kind of remind me, I know earlier too, you had mentioned this idea of using the tool to assess for dynamic LVOT obstruction. And that's something that can sometimes be challenging to identify clinically or even on surface echo. So maybe we could take a quick step back and you can highlight that particular process for me.
Yeah. And that's not something that we thought we'd find in the acute trauma literature, the acute trauma population. But actually in our study, we found several cases of severe dynamic LVOT obstruction during the acute resuscitation of trauma. And these patients actually were treated with IV beta blockade during their resuscitation to minimize it. And I think that as we're doing TEE on sicker patients during more kind of resuscitative and acute processes, we're finding this phenotype where patients behave persistently hypovolemic. We're giving them fluid, we're giving them fluid, we're giving them fluid. They're not bleeding, but we need to keep giving them fluid to really support their blood pressure. But when you look at the heart, there's this physiology where it's similar to the Hokum patient that has obstruction of the left ventricular outflow tract due to the anterior mitral valve leaflet and a combination of low end diastolic volume, lots of adrenergy and kind of a hyperdynamic heart, relative hypovolemia contribute to this physiology that can actually be life-threatening. Most of the time, I think when this happens in trauma, we just give fluids, maybe they go on a vasopressor and that kind of takes care of it. But some patients where it's very severe might need negative inotropes like beta blockers to really control things.
Yeah, I think it's a fantastic point. I mean, dynamic LV outflow tract obstruction is one of these sort of zebras that's not really a zebra, I think. It's kind of like, in an episode we talked about like Zorses, things that, seem rare but are actually more common than you think. And this is exactly the circumstance where you have to worry about it, right? Where somebody has, let's say, longstanding hypertension, they have kind of a narrowed outflow tract, but then it's a change in loading conditions, right? They're hypovolemic and they're hypercatecholaminergic from pain, trauma, etc. And that sets them up for this. And so I think it's a really good point that, like, often in trauma patients, we succumb to this satisfaction of search, right? You see a bullet on the chest x-ray, that must be the cause. You see blood on the floor, that must be the cause. And that's not always the cause. There can be medical comorbidities underneath. And I think it's going to be really exciting moving forward to see how often, especially in people who have a high risk for dynamic LV outflow tract obstruction, how often that's present in the trauma bay.
Yeah, Nick, I think that's actually a super astute point, I think, because, in ATLS, we talk about distracting injuries and the perils of distracting injuries. And in your trauma patient, sometimes, problem numbers 1, 2, and 3 may be distracting injuries and lead you astray when it comes to those kind of medical comorbidities that could be actually driving what you're seeing on the monitor and what you're seeing with the patient. So definitely a nice tool to help mitigate some of that anchoring bias that we may encounter in some of these folks.
Right. So I think our listeners right now are probably like, wow, this sounds great, but what's the catch? So specifically, what are the downsides, risks, hazards associated with TEE?
Yeah, there certainly are risks to TEE, but admittedly, the risk is actually very low. And this was based on certainly the cardiology literature for routine TEE, which arguably may not apply to the resuscitative setting where there's different experience of providers. But we actually looked at this in a scoping review we did with over 6,000 patients. And the good news was there's actually no cases of esophageal perforation or death reported in the literature. And that echoes our own center's experience with well over 1,000 TEEs where we haven't seen that. Now, there are risks described, particularly with sedation and kind of airway concerns and aspiration for some critically ill people. But when the patient's intubated, these risks, and they're in a resuscitative environment, I think these risks are much, much lower. And then there are cases of oropharyngeal bleeding during insertion, mild GI bleeds sometimes requiring transfusion, but the rate of complication for these is in the single digits, and it's certainly on par or much lower than the complication rates for other tools that we would have no hesitation in inserting during a resuscitation: cortices, central lines, PA catheters. And when we factor the invasiveness and also the infection risk of indwelling and invasive catheters, I think TEE actually measures up fairly well. I think it might also be worth maybe mentioning just how we approach insertion at our institution. So what we normally do is we restrict it to intubated patients. We have them deeply sedated or paralyzed. We use a bite block to protect the probe and to help kind of make sure that the mouth stays open and we don't damage the teeth. And then one thing that we do is you can either do it with a jaw lift in one hand while you're inserting the probe. You could do a two-person approach where one person holds a really good jaw thrust and you're inserting it to really lift everything anteriorly so that you have a straight shot at the esophagus. Or you can use a video laryngoscope or a regular laryngoscope. And I know that that's been advocated by many ED programs that are using resuscitative TEE. We're so good at using video laryngoscopes, and it's just kind of like placing a OG tube using a laryngoscope. You can see exactly where it's going. You can make sure it's midline, and that might help minimize the risk that you're pushing on either side of the oropharynx and causing oropharyngeal trauma and bleeding. And I think with this, it's a safe procedure, and it's certainly something that anyone who is familiar with inserting an OG tube can really do. It's not a complicated procedure once you've done it a couple times.
No, I agree with that. And, I think it reminds me a little bit of like inserting a Minnesota tube where like it's this big tube, you have to get it in the right place, and using a laryngoscope is a great way to guide it. It's a little bit counterintuitive because normally we're like, we want to go anterior, here we want to go posterior. But once you get your bearings and you're aiming for the right target, that probably makes it a lot easier. As General Omar Bradley liked to say, amateurs talk strategy, professionals talk logistics. We love to get in the weeds on critical care time, and I want to talk some logistical details with you. So first off, like at your institution, how does this work? Where is it kept? Who has access? How do probes get cleaned? Because it seems like that's going to be a sticking point for implementing resuscitative TEE in a lot of programs.
Mm-hmm. We have multiple Resus-TEE probes, which are just regular TEE probes that work with our kind of normal critical care ultrasound machines. We have them in plastic totes or big boxes in the ICU that are marked clean on the probe and on the box when they've been cleaned. We allow our ICU fellows, POCUS rotators, POCUS fellows, and intensivists to have access to them. And we actually don't have a formal credentialing program here because we treat this like many of the other procedures we do in the ICU where you need to have somebody teach you it. You have to understand the indications, the proper cleaning, storage, how to interpret it. And then once you're shown it and you demonstrate competency, you take this on as a skill that you can use. But one of the advantages we have is that all of our TEE images are reviewed and image archived and discussed and feedback's provided on the actual interpretation to provide an additional level of safety, particularly because these are often done during the midst of a resus where you might miss more subtle findings or the integration may not be optimal. So this allows us to kind of have serial improvement in our own skills. There is some literature on this as well, and this suggests that perhaps after about 10 insertions, even in a simulated setting, people obtain the necessary proficiency to obtain core Resus-TEE views. And I should mention that this Resus-TEE spans from very, very simple core views designed to answer big questions like tamponade, LV failure, RV failure, to much more complicated, nuanced hemodynamic decision-making. And to answer those kind of very big questions with Resus-TEE, including, I should have also mentioned CPR placement, I think somewhere in the 10 to 20 insertions and 10 to 20 reps, be that simulated or real life, is probably enough to get that, especially if you have experience with POCUS or transthoracic echo, where the views are different, but they're kind of just flipped. And assessing an LV on TEE versus TTE, assessing an RV on TEE versus TTE is all very similar. And so I think there's a lot of transferability between these different modalities.
So I'm curious, for those of us that aren't working in your ICU or those of us that are already practicing, if we're interested in adding this to our armamentarium, how might we go about doing that? Is there some training or a certification process we could pursue, something out there?
Yeah, there's no strict training or certification, and in many regards it's similar to POCUS in that I think people need to be taught indications, how to use it safely, how to care for the machine, including cleaning, how to interpret it and integrate that into practice. There's certainly courses available, and I'll certainly plug the Resus-TEE course put on by Felipe Turan. It's a fabulous one-day course, and I've been an instructor at it for several of them. You cover on simulated patients, everything from probe insertion all the way to interpretation. And at the end of it, I think most providers are very, very comfortable applying this in their own clinical practice without supervision after that, just given the quality of the course. We've also run focused half days for ICU programs for fellows and intensivists. And again, really with a simulator, some experience with point of care ultrasound, and just like a bit of practice, I think it's quite feasible to have the core Resus-TEE skills to apply it at the bedside.
Excellent. Okay, so follow-up question. When are you guys going to be in Seattle?
Yeah.
I think there is one on the West Coast, though.
Okay, yeah, sounds great. I'm down.
Yeah.
I've gotten a little spoiled personally because I work with a lot of cardiac anesthesiologists, so usually they are like all over it. But I want to get some more hands-on time. So maybe you could be my instructor at one of these.
Love it.
Another question I wanted to ask. So, you see products that are marketed more at the ICU. It sounds like what you're doing is you're using the same probes that the cardiologists are using. So your hospital has like one pool of TEE probes. What are your thoughts on like these like ICU marketed or single-use disposable TEE probes? Do you think that's a must-have to set up a resuscitative TEE program or not?
You know what? I'm a little bit less enthusiastic about those. I think the main benefit for TEE and really POCUS in general is about phenotyping shock. You can put the patient in the right bucket. Is this RV failure, LV failure? And once you have that done, the serial and iterative refinement of patients over the span of days can be done by other tools. Looking at end organ perfusion, be that cap refill, modeling, lactate, urine output. There's other markers we can use to titrate our therapy. And also with the regular TEE probe, you can leave it in for an intubated patient for 4, 6, 8 hours potentially to image the patient over the span of a longer resus. Now, I will just say don't leave it on the whole time because it can overheat. So you want to freeze the probe. But we sometimes leave it in for the duration of this acute resuscitation where things are really changing dynamically and we want that really high quality image. So I would rather have that high quality images for a slightly shorter period of time than one of the disposable probes left in over a few days. I'm not sure that would really change my management as much. And now, Nick, you also mentioned that just one comment about the TEE probes being kind of in the general pool. We actually have separate TEE probes for the ICU, for the emergency department that are labeled so that when they get clean, they come right back up to us, similar to how we process bronchs. And we just send them down to processing, they'll clean them for it and send us back within an hour or two. So it's a really great system that's been set up here.
Nice. That sounds like one of those really crucial details that's helpful because like you can imagine you put a bunch of money into these probes and then suddenly cardiology has a bunch of extra probes and you have none. So smart to label what's yours. We have an ultrasound machine that has about 20 things that say ICU on it, like from every possible angle. So it can't possibly go anywhere else.
But it does invariably.
It does. Yeah.
Yeah. So I know we want to start to close out by talking about a couple things, medical-legal considerations here, the future of TEE, resuscitative TEE. One question I have that might kind of dovetail with that nicely is when I've discussed this modality with cardiologists, they're always very, very concerned about how we're going to utilize it and the determinations we may make. I think they're sort of like, oh well, we have to get X number of images and where we spend a lot of time training on this, whereas as you said yourself, Ross, there's no kind of formal training for this. So how do you push back on cardiologists that are very I'll say somewhat understandably concerned that folks that don't have as many contact hours with the device may overstep their training?
Absolutely. I think the same argument and comments have been made about point of care ultrasound more in generally. What happens if somebody overinterprets a echo finding? I think the key is that we're not trying to replace cardiology performed TEE. We're trying to answer a specific question for a critically ill patient that's dying in front of us. We're trying to say, why are they dying and what can we do to stop it? And if we're using POCUS in general, and if we've accepted that ultrasound of the heart is a good thing, why not just get the best quality images to make those decisions? The invasiveness of TEE is really minimal compared with many of the things that we do in the ICU to patients on a routine basis. And I think that intensivists or emergency physicians or anesthesiologists are perfectly situated to do this procedure. And so to me, it's not really a discussion, and it's certainly not one that we have at our institution, and the two exist in harmony. We have patients in our ICU that undergo cardiology-performed TEE, and we have patients in the ICU that undergo Resus-TEE, and it depends on what the indication is. I'm not going to try sizing a valve, an aortic valve before replacement. The cardiologists and cardiac anesthesiologists, they're all over that. But similarly, when the patients are resting at 3 a.m, the cardiologist isn't going to be there with their TEE. I'm going to be there placing it down to help my patient kind of in the middle of the night. So I think it's kind of a false dichotomy, and it's not a discussion that should happen. It's just how can we use this optimally and teach people about the benefits, but also limitations of the modality. And there certainly are a lot, and that's just part of any new technology and trying to innovate within medicine. There's always going to be people pushing back a little bit, but hey, let's just provide the best care for our patients and focus on that.
Fantastic. I think that's a great answer, and something that I definitely can get behind. And I think most of my colleagues in cardiology can as well. I think the key there is that they serve different purposes in different hands, except for the fact that at the end of the day, we're all trying to provide the best care possible for our patients. And so with that all being said, I'll get back to kind of what I alluded to earlier. What is the future of TEE then in the hands of the intensivist or the emergency medicine physician or those kinds of folks? Where do you see this going?
I think that we're at a really exciting time for resuscitative TEE because the evidence-based supporting its use is starting to grow. And I have to shout out the Resus-TEE collaborative led by Felipe Turan. It's a collaborative of over 50 hospitals right now that are actually using resuscitative TEE in the emergency department, ICU, perioperative setting, and are recruiting patients into this prospective registry to answer some pretty incredible questions. For example, does CPR placement impact long-term neurologic survival for patients after cardiac arrest? What are the hemodynamic phenotypes that we're seeing in the ICU? What are the hemodynamic phenotypes we're seeing post-cardiac arrest? And these really exciting questions can only be answered with TEE because there's no other real-time physiologic anatomic data that we can get during cardiac arrest. And maybe a shout out just if you are using TEE at your center in resuscitative TEE and want to recruit and be part of this amazing registry, reach out to kind of Felipe Turan through the Resus-TEE project. It's resuscitativetee.com. And if you check that out, there's tons of opportunities to become involved, and we'd love to have you as part of this great collaborative here. But I'm just excited to see where the literature takes us, and hopefully we can just improve the survival for some of the sickest patients that we have.
It's an exciting time indeed. How should people go about getting a Resus-TEE program off the ground at their hospital? People who are listening to this who are like now really excited.
Yeah, admittedly, it's tough. And so I think, first of all, you need a champion, somebody that's really going to drive this forward, whether that's yourself or somebody else. I think I would first look for a center that has an established POCUS program and POCUS infrastructure, because you need to have a way that you have machines, you need to have some sort of image archiving, I think, or at least certainly very, very helpful. Then you have to figure out how you're going to acquire a probe, maintain it, clean it, who's going to have access to it, how are you going to review those scans. I should say, though, that this doesn't mean that this has to be done in an academic institution or an ivory tower. This can be done and has been done very successfully in community emergency departments and ICUs. It's really anywhere where there's an interest and somebody that's a really big champion for this. But I think having that familiarity and departmental experience with point of care ultrasound is a nice first step.
All right, so excellent overview of resuscitative TEE. As a bonus, why don't we talk about a slightly adjacent topic, which is medico-legal liability for point of care ultrasound. I know you recently published a case analysis of this, basically covering all the recent cases in Canada. What can we take away from that?
Yeah. So we recently published a closed case analysis of Canadian medico-legal POCUS. And in Canada, it's worthwhile saying that we essentially have one firm that provides medical legal coverage for all physicians, called the Canadian Medical Protective Association. And all hospital, college, legal complaints come through the CMPA. And so it's the world's largest medical legal repository here in Canada. And we actually, in collaboration with the CMPA, looked for any cases related directly to the application of point-of-care ultrasound. And we actually found 15 cases that were related to point-of-care ultrasound. Importantly, the most common reason for medical legal action against a physician was failure to provide POCUS when it was indicated. This actually mirrors a lot of the previous literature on this topic. But importantly, we actually also found cases where inappropriate application of POCUS, for example, not integrating it appropriately into the clinical pathway, resulted in medical legal action against a physician, or cases where inadequate documentation was implicated. Now, if you go and read the paper, there's not as much nitty-gritty, gory details as everyone wants, but that's partly to protect patients and physicians as well. And so we worked with the CMPA to come up with a meaningful analysis that didn't kind of violate the rights of patients or physicians. So that was done in close collaboration. But kind of my take home from it is that POCUS is here. Like, it is an expectation that if you're caring for critically ill people, you are applying it when it's indicated, and failure to do so can be problematic for you, and it certainly is problematic for your patient. And so I think that if you're trying to get this in your department, if you're trying to get this in your hospital, and you need like a stick for your administrators to justify the purchasing of a machine or something like that, I think this paper might be able to help you. And I'm certainly happy to connect as well and give my 2 cents on why we should be using POCUS kind of for all of acute care medicine.
Yeah, I think that's a really great point. I think, like there's always laggards in medicine. There's always people who are like resistant to what's new. But I think it's a really key point, which is that the failure to do standard of care medicine, which includes point of care ultrasound, is more likely to get you in trouble. It's also worth remembering that, even though point of care ultrasound is great, it's one data point or one set of data. It's not, you have to put it in the context, as you said, you have to integrate it with your patient. So, if you're seeing very, very different things in one imaging modality than another, or your hemodynamic measurements are very different, I think that's a situation where you should pause, maybe question the reliability of your measurements instead of hanging your hat just on POCUS because it's fancy.
All right, guys. So today we discussed transesophageal echocardiography, or TEE, in the ICU with Dr. Ross Prager. Fantastic discussion. I think we all learned a lot. I just want to emphasize some of the key points that I took away from this discussion, and then kind of see, Ross, if you have any other thoughts. So TEE, I think we can agree, is a useful diagnostic tool in certain cases, particularly cardiac arrest, undifferentiated shock, has some really interesting uses in the trauma patient. That being said, it's really not a substitute for what a cardiologist or maybe a cardiac anesthesiologist might do with the TEE probe, for example, to assess valvular pathology. This is a very specific use, and I think it's important for us to remember that. And I would say, based on kind of our discussion, if you do work in an ICU, critical care TEE or resuscitative TEE is definitely a reasonable skill to consider acquiring, to adding to your toolbox. But Ross, I think one thing I took away from your approach to this is really don't think of it as its own modality, its own unique tool. It's kind of an extension of the POCUS drawer within your toolbox. And it's one that can provide some tremendously helpful answers in a very timely fashion to change the tide of battle in certain cases, so long as that tool is in the hands of a trained clinician. Does that sound reasonable, Ross? Or what else would you add?
Yeah, I mean, beautifully put. I think that it might seem like Resus-TEE or critical care TE is only a tool that can be used in academic institutions, but really this is not the case. And in fact, I think a lot of the greatest value is when there's not that cardiologist there at 2 a.m. Who can come down the hallway to do the TE. And when you're it and you need the best tool to diagnose your patient, to manage your sickest patient, to save their life, TE is just perfect for that. If you can put in an oral gastric tube, you can place a TEE probe and you'll get near perfect images within seconds to really provide the best care for your patient. And I truly think that Resus-TEE will become a cornerstone of 21st century resuscitation, and hopefully we'll be able to save some lives.
Perfect note to end on. I just want to plug you, Ross, real quick. I know you've had some amazing threads on Twitter or X or whatever it is, and I think our listeners should definitely go ahead and follow you, because you've had some great threads recently that I've shared. But I mean, they should hear it from the source. Where can people find you on the interwebs?
Yeah, follow me on Twitter or X at Ross_Prager.
Excellent. Well, thank you so much for coming on. And, we've come to the part of the show where we like to say thanks. First, thanks to our awesome guest. Thanks to all of our listeners who have left us reviews, comments, 5-star reviews in particular. I was just looking at these the other day, and I was like so happy seeing some of the things people wrote. Like, we read everything you write. We really appreciate your words. So please keep them coming. It helps other people find the show. We'd also love to hear from you. You can tweet or X at us at Crit Care Time, or individually at Nick M. Mark or at Askins Razor. You can follow us on Instagram and Threads. I was thinking the other day we should do like a mailbag episode with listener questions. So please hit us up with questions. This is a good way to reach out to us, and we would love to answer your questions on a future episode.
Yeah, I think we have some physiology questions that we plan to dive deep into once we actually figure out the physiology ourselves. Important
first step.
Yeah, so we're looking forward to that. In keeping with giving thanks to, various entities, we obviously need to thank our sponsor, C-Star Medical. We're fortunate and we're grateful that this episode and all the episodes that comprise Season 1 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website. That's www.seastarmedical.com to learn more.
And before we go, we'd like to thank our team, our podcast team that helps us make this possible, our editors and production team over at Podpaste, and certainly Kurt Belknap for our awesome theme music. Finally, disclaimer time. This podcast and all related media, including but not limited to animations, graphics, and videos, are property of Critical Care Time. Please share our content, but cite your source.
And the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening. I'm Dr. Cyrus Askin.
And I'm Dr. Nick Mark. See you all next time.